Welcome to part 3. We are here talking about different types of SVTs. Now, supraventricular means any tachycardia that is originating from above the level of the ventricles. Above the ventricles, we have the atria and the atrioventricular node. We've just spoken about atrial fibrillation and atrial flutter. What is multifocal atrial tachycardia? Basically, we have multiple ectopic foci in the atria that are all giving rise to different impulses. This is commonly seen in patients of COPD and congestive heart failure. Now, why is that? Because in COPD, we have pulmonary venous congestion, which is coming back to the left atrium. And in CHF, we have venous congestion of the IVC, SVC coming to the right atrium because of persistent dilatation, remodeling, and fibrosis. Hence the development of multiple abnormal foci in the atria. Now here I just want you to look at the rhythm strip. You can see that the rate is irregularly irregular. So for the heart rate, in 30 large boxes I'll have 1 minute. Inside that I have 10 QRS complexes here, and 10 multiplied by 10 is 100. So we have a heart rate of 100 BPM. It can go all the way up to 250. Now in multifocal AT you will notice that there are a lot of PACs along with just fibrillating waves at times. A nice way to diagnose MAT is when you have 3 distinct P-wave morphologies, as you can see here. Now we look at regular atrial rhythm. So instead of multi, you have a focal atrial tachycardia with a single ectopic source in the atria. Now in FET ka ECG, if you look at it, leads 2-3 AVF. Here your P waves are normally upright, but if you look here, you have the P waves inverted. Whereas ulta, if you look at V1, your P waves are upright. Now point to note here, P wave morphology here is abnormal, but it is consistent throughout the ECG, unlike MAT. So this is done. Just note that atrial flutter can be both regular and irregular. Now this was one pathology where there is a focus problem in the atria. But what if instead of foci, we have accessory pathways that are going to cause pre-excitation? If you have an abnormal structural pathway which is present as a bundle between the atria and the ventricular impulses come, then from the AV node it goes up via this bundle and goes back and comes and forms this re-entry circuit. This is a smaller circuit that is formed, so this will actually have a faster rate, so therefore giving rise to a tachycardia. Now if it came to the AV node first, it is orthodromic. And if it went via the pathway and then to the AV node and then it continued, that is an antidromic pathway. Also, by the way, we're talking about the bundle of Kent, and this is the Wolff-Parkinson-White syndrome. Now see, because of this accessory pathway, the impulse is entering the ventricle before its destined time. Therefore, there is a pre-excitation of the ventricles, which you can clearly see on the ECG because you can see that the ventricles are getting excited before their time. This is early excitation of the ventricles, seen as this triangle over here. This is called a delta wave at the start of the QRS complex. Also, because of the accessory pathway, we have bypassed the AV node, so you see a very short PR interval. Now, WPW is type A if the accessory pathway is on the left side of the heart, and type B if it is on the right. So we can see the short PI and the delta wave, but along with that we can see that V1 is showing us a prominent R wave. This means that the accessory pathway is on the left side. This is a different ECG. Again, we see a shortened PR and a delta wave. But here in V1, we are seeing a prominent S wave. That means the accessory pathway is on the right, and this is a type PWPW. So this was re-entry circuits, and we just spoke about atrioventricular re-entry tachycardia. There was a proper structural anatomical accessory pathway here. But we may also have a functional circuit. If we talk about the AV node, a PAC may come via a slow pathway and a fast pathway. Normally, slow and fast pathways cancel each other out and they go down as a normal. In some cases, the fast pathway might be in its refractory period, and as a result, the slow pathway gets conducted. We still get a sinus rhythm. But in case its refractory period is over, the slow pathway will conduct retrogradely back up the fast pathway. This becomes a re-entry circuit where the impulse goes continually. It leads V1 and V2, you will get a pseudo R wave. That means the P wave actually comes after the QRS and is hidden here. See you in part 4.